இதுலேயே பண்ணிக்கிறேன். க்ரீனில் பட் பாயிண்டர் ஸோ இதுவா கீழே இருக்கிறதா? ரைட் தான்.
டெய்லி தான் அடிக்கிறீங்க, அப்புறம் என்ன? ஏன் நினைக்க என்ன படிக்கிறாங்க? என்ன படிக்கிறாங்க?
விநாயகா மிஷன்ல
சார் இல்லை நினைக்கிற மாதிரி அவங்க கிடையாது. டெரரிஸ்ட் டெரரிஸ்ட் நாங்களும் முதல்ல ஏமாந்துட்டோம் சார். ஐயோ பாவம் நினச்சி ஏமாந்து அடி வாங்கி அப்புறம் தான் புரிஞ்சுது. கேர்ஃபுல்லாக இருக்கு.
சார் உங்களுக்கு எதிராக தானே பேசணும்.
அதுதான் கவர் பண்ணுறேன்.
Please start. Please start, Ashok. After 4 minutes, that they will switch off the mic.
Oh, goodness. Okay.
All the best.
Thank you so much. So, respected judges, ladies and gentlemen, a very good morning. So, when I was given this topic, my first reaction was, where is the debate? It's an obvious choice. A monofocal lens is what you would advise for somebody with unilateral cataract. So, let us all admit one thing, that we all want to be spectacle independent at all times, and so do our patients. But we also understand that the biggest challenge we face today is the loss of accommodation which happens after cataract removal. That said, the important thing we must help our patients take a decision is that there should be a qualitative improvement in vision also, other than just quantitative improvement in vision. And this has been proven in literature with a lot of visual function questionnaire and visual quality of life questionnaire, which have said to be better assessment systems of visual gain rather than just checking the visual acuity. So in this talk, I'm assuming that there is no congenital or developmental cataract, and if we should look at the common causes of a unilateral cataract in an adult, it is infection, inflammation, and trauma, which means we are already talking about a compromised ocular health. So in this condition, it would be safest to go with something which is time proven. And the other thing is, these patients will be slightly younger in age group and will probably have an other eye which is phakic. They'll probably have a refractive error in the other eye, or at least a presbyopic glasses. So if one eye has already got need for glasses, where are you giving binocular vision by making one eye spectacle independent? So then in the ocular examination, if we should keep these causes in mind, then pupillary distortion or an active pupil like in a young patient would be a contraindication for a multifocal. Most of us, or ocular aberrations, are not checked so frequently before a multifocal is advised, which means we will be doing more disservice to the person. Astigmatism, ocular comorbidity are other newer problems which will add on to the issue when we decide to choose a lens other than a monofocal. Cost is an important factor. In fact, there have been many papers on this, especially from the British side. NHS has decided not to approve this because they have not seen any major gain of a multifocal lens over a monofocal in a cataract surgery patient. So if we should look at the primary issues, it is the lack of qualitative improvement in vision. So visual phenomena, starbursts, glare, halos have been reported n number of times in literature. The first thing a patient with a unilateral multifocal lens will say is that he or she needs more light to read compared to the other normal eye, and the loss of contrast is something which is not very acceptable to them when they are able to compare with the normal eye. So currently we must also understand that all along we keep talking about distance and near vision, but in probably today's world it is the intermediate vision which is more important, and most of us are reading in gadgets today. So probably the newer lenses, the extended depth of focus lenses, and the concept of making the eye micro monovision, that means you tailor make the refractive error for the need of the patient and get rid of the qualitative problems which a multifocal might give. Okay, thank you. So are probably the two aspects we should look at in helping these patients with unilateral cataract. So to conclude, I would want to say that presbyopic correcting multifocal lenses are in market. We are using them, but we have still not got away from the problems of them because of the fact that light splitting is the primary science with which it works. And let us also look at literature to say that majority of the lenses implanted are monofocal, and a large number of multifocals have also been explanted for reasons because of drop in qualitative improvement of vision. Thank you very much.
Good morning. For the paucity of time, I'd like to start right away. I'm going to talk about trifocal implant and unilateral cataract. So there's a disclaimer. There's, of course, no financial or proprietary interest, and this is just a guideline or not a preferred practice pattern. These are not cookbook recipes, so use judiciously, use your discretion while choosing trifocals in your patients. So we have a changing profile of patients opting for cataract surgery. We have the patients then with a dense, dark, mature cataract where they couldn't differentiate either between their car or their cow. And now you have an active patient with an active lifestyle who plays tennis in the evenings, and he's extremely dependent on digital devices, and he's opting for surgery much earlier to be spectacle independent. The holy grail in ophthalmology has always been the perfect vision intraocular lens. It is always, the debate is phacorefractive surgery. So we should aim for spectacle independence if the patient desires so. So we have a multitude, a plethora of IOLs, including the trifocals, the continuous range of visions, and the fusion IOLs. Surprisingly, when I searched in the literature for unilateral cataract, I assumed it's always uncomplicated cataract, unilateral cataract, and there was two interesting articles, one in BJO and AJO, which concluded that unilateral implantation of trifocal, one is PanOptics and other one is the Physiol, had very good patient satisfaction assessed by the V14 questionnaire. They had very good uncorrected distance and near visual and intermediate visual acuity. However, the near visual acuity was better with binocular implantation, and it was a motivation factor for these e-metro with presbyopia. When they have a unilateral trifocal implant, they opt for the other eye. So these are some few cases I like to highlight. Here you have a retired banker who had presented to me with unilateral cataract. These kind of cataracts, Dr. Uday Devgan calls them as Californian cataract. It's neither here nor there. Soft, early NS. They want to be spectacle independent. They don't have any nighttime driving. Don't hesitate. Go ahead with the toric trifocal implant. For the paucity of time, I'll skip the video. I'll share it at the end of the presentation. Another case, I have another elderly gentleman who is a myope all his life. He's fed up of wearing glasses. Now he's developed PSCC or PPC, and he desires freedom from spectacles. In another case, you should counsel the patient for a trifocal, of course, with guarded prognosis, because you don't know you'll have a PC tear. So unilateral cataract, trifocal implant is my choice. You need an extremely motivated patient for having spectacle freedom. He should have an easygoing personality, should be a voracious reader who uses digital screens, and of course, no night driving. Ideally, a patient who's hyperope with presbyopia is a good patient. There should be no retinal or macular pathology. They should have a normal tear film and eyelids, no history of LASIK or refractive surgery. So you should aim for the bullseye in these trifocal implantation. So whenever I counsel a patient for trifocal unilateral cataract, look carefully for the tear film status, do an optical biometry, look at the corneal topography and the aberrometry. Don't miss out subtle signs of keratoconus because they are all a strict norm. And even if the macula looks normal clinically, go ahead with an SD-OCT. Like you could see, you will have subtle changes like parafoveal telangiectasia when picked up with SD-OCT. It is a strict no for unilateral cataracts. And please do check for ocular dominance. I prefer implanting the non-dominant eye first with trifocal IOL because they give better near and intermediate vision, then plan for the other eye subsequently. So another important aspect is look for angle kappa. So the angle kappa is between the visual axis and the optic axis. Here you see the lens is always centered along the limbal center. So we have a large angle kappa more than 5 or 6 degrees. Don't counsel them for trifocal IOL. So the pros of implanting a trifocal implant: you have a wow factor on POD1, ability to start reading immediately from day 1 or day 2. They have freedom from spectacles, early return to their job, and they are motivated to have the fellow eye with trifocal implant. Of course, there are downsides: the nighttime driving issues, glare halos and starbursts, loss of contrast sensitivity, and of course the cost. So who said that monofocal IOLs don't cause visual disturbance. This is the slide I bought from Uday Devgan's cataract coach, where he says even these negative aspheric IOLs, monofocals, when they are decentered, they are causing coma and significant spherical aberrations. So you should aim for perfect centration of these lenses, otherwise they are prone for causing aberrations. So this is a slide which we use to counsel patients for a monofocal or trifocal forced surgery. Here you can see with the monofocal IOL, you have difficulty in reading and intermediate vision, whereas with trifocal it's much better. I'd like to conclude by saying trifocal IOL or EDOF is your preference. Here we had Carlos Alcaraz, who won the Wimbledon Championship, defeating Djokovic. So start a new era, don't belong to the old one. So chair time is spent is crucial, and always remember, under promise and over deliver. Thank you for your kind attention.
Atishwar, how do you counsel the patient post-operatively? Is a unilateral cataract. Other eye will be again presbyopic. Do you give glasses near each
Other eye,
other?
whether it's a hyperope or a emetrope, is important. So if the patient is a hyperope with presbyopia, they are extremely motivated to get the other eye done within a week. However,
If the other eye doesn't have a cataract, what is your choice? What will be your advice?
no, we don't counsel the patient if they don't have cataract. But like I said, when they have, it depends on the age and their lifestyle. If they're looking at spectacle independence, we can always counsel them for refractive lens exchange to get a trifocal implant in the fellow eye so that they are spectacle independent. Because binocularly implanted trifocals give better near and intermediate vision than monocularly implanted trifocals.
So, and thanks so much. Then that was a beautiful presentation, Atishwar.
Thank you, sir.
Ashok, I have a question for you, please. So, when in your patient with a unilateral cataract where you put a monofocal, do you aim for a distant target, intermediate target, or a near target when you see the patient?
Yeah, I would probably, as I had mentioned during my talk, find out the need of the patient, see the refractive error of the other eye, and then decide. I will try to match it maybe with the refractive error of the other eye. Again, there's a lot of chair time needed. If he is a person who's like a banker or an IT person whose desktop work is going to be more, I would probably aim for an intermediate range and then give him glasses for the rest.
Will that mean a minus 0.75, minus 1, 1.25?
Minus 0.5 to 0.75 is a safe bet. You will never go wrong with that.
Thanks so much. Now, this is for will you all choose to put a monofocal in these patients? Please raise your hands. Or will you all choose to put a trifocal? Trifocal. And those who will put a monofocal? So this is interesting. So we are evenly divided, 50-50. Thank you. Srinivas, please.
Good morning, respected judges and my dear limited audience. So today my talk is on post-laser visual correction eye and the premium IOL. Definitely yes. You want to have your practice as a premium practice? Definitely select this. Premium IOL சொல்லிட்டு பென்ஸ் கார் தான் premium கார். என் ஆப்பனண்ட் பக்கத்தில் இருக்கிற ரிக்ஷா தான் premium கார்னா எவனா ஒத்துப்பானா? It will not happen. This is Agarwal Eye Hospital, Erode. This is Agarwal Eye Hospital, Tirupur. This is Agarwal Eye Hospital, Salem. This is Agarwal Eye Hospital, Coimbatore. நான் என்ன Agarwal Eye Hospital ஆட் பண்ணுறேன் காலையில். All these places, a small pupil, post-retinal detachment cataract patients, premium lenses, VIP patients, post-refractive premium IOL. Judges, please note, post-refractive premium IOL. He is the operating surgeon. If you want, I have the data. I cannot show it in public. How many cases he has operated? All these places he only operates. He cannot best, because Sriram, who has organized a conference well, has given the topic. He is going to talk this. But his practice is different, judges. His practice is different. See, to understand more coming to the subject, how I counsel the patients in all these premium lenses is, first of all, understand the cornea as a normal positive spherical aberration. Post-refractive, myopic refractive surgery patients will have more positive corneal aberrations, and hyperopic refractive correction patients will have more negative corneal aberrations. Patient should be happy at the end of the day. Most of my premium IOLs are not very rich patients, or all on average patients. They only choose me the premium lenses in my practice. And remember, all the multifocal or trifocal lenses, everywhere the contrast is reduced worldwide. Don't you think ophthalmologists implement that? They do micromono, 0.5 diopter. Still, all of them do that. Everybody knows contrast sensitivity is reduced. All they do is do an extra chair time. Convince the patient of not using the glasses. See, first of all, here, the patient has already decided at 20 that he doesn't want glasses. At 40 or 50, when he is having a cataract, you cannot be a dictator and say, no, நான் எனக்கு monofocal தான் பிடிக்கும், நான் அதை தான் போடுவேன். You have to take an extra chair time, tell him that the contrast sensitivity is reduced and all those things, and convince him, and definitely he'll get convinced because he doesn't want glasses at 20 years. The myopic IOL, when it's a myopic refractive corrections, always there are various lenses are there. You use a technique monofocal lenses which has more negative spherical aberrations, which will neutralize the positive aberrations which is created by the post-myopic thing. A hyperopic refractive correction use a more positive spherical aberrations, something like an Envista. I am not branding the lenses, but these are the lenses which are all giving all these things. In a case of a complex, misaligned, irregular laser aberration patient, choose an aberration-free lens that is very less sensitive to the optical decentration. And if there's a large angle kappa, all these things you have to look into it. You can use a AT Lisa trifocal lenses which has a large central optical zone, which will not dependent on the optical centration. And in general, this is from the recommendation from the American Academy of Ophthalmology. Up to -4 or plus 1.5 diopter patients are very, very happy post-operatively to use a premium lenses. And if there is no history, for example, Dr. Ramya, Dr. Kavita Lakshmi, all these people who are the laser surgeons, இன்னைக்கு நாங்க ஸ்மைலுக்கு அனுப்புவோம், ஒரு டோப்போன் போடுவாங்க, ஒரு ஸ்கேனு, அந்த ஸ்கேன்ல வந்து சைக்ளோன் படம் மாதிரி இருக்கும், எங்களுக்கு புரியாது. அதுக்கு அடுத்த நாள் திக்னஸ் இல்லைன்னு சொல்லி பிஆர்கே பண்ணிடுவாங்க, பேஷண்ட்டுக்கு தெரியாது, ரெஃபரிங் டாக்டருக்கு தெரியாது, அந்த ஆபரேட்டிங் டாக்டருக்கு நெக்ஸ்ட் டே தெரியாது, ஏன்னா அவங்க ஓடி லிஸ்ட் பெருசு. ஸோ when there is no history, always remember the central steepening is a hyperopic correction and there is a central fracturing, it is a myopic correction. To understand when you are selecting the lenses, keratometric leadings are generally lower than the normal eye. So in a flatter cornea and myopic correction, the ratio between the anterior and posterior corneal curvatures are altered and asphericity is changed from prolate to orbate. In an oblate cornea, the cray reading is much in the paracentral area is more higher than the central area. IOL power estimation always underestimated in SRKT and Hoffer Q. And remember to place.
Sum up, please. Time.
One last slide, I will say, he was my mentor when I joined post-graduation. And because my Kripa Shankar neurosurgeon said, go to his clinic and see how smilingly he says. First patient was a silicon RA multifocal post-op patient, somewhere
Maybe
operated. He was counseling
We
it.
can have a personal discussion.
Yes, sir. No, sir. And he had opened all these accounts. And he was doing a premium practice at the time. Now he will say monofocal. நம்மகிட்ட இந்தியன் பேங்க் அக்கௌண்ட் தான் இருக்கு. நம்மளும் இந்த மாதிரி அவரை மாதிரி அக்கௌண்ட் எல்லாம் ஓபன் பண்ணிட்டு ஒரு 15 வருஷம் கழிச்சு மோனோஃபோக்கல்னு சொல்லிக்கலாம். தேங்க்யூ.
Thank you. LS. Okay.
Good morning, everybody. Actually, my friend did the posters, everything, saying that I am doing all premium IOLs in the post LASIK vision corrected patients, but it's not the fact. Actually, in our era, during our PG days, we have seen the LASIK has been boomed and there were a lot of patients underwent LASIK. That time, LASIK had not much advantages of what at present day we have. So there are a lot of other factors which influence the LASIK, like pupil centration and irregular ablations, all those things, which those are the patients now we are seeing as cataract patients, like the almost 20-25 years after LASIK. So now I am going to discuss only about those patients. So these are the points which we had to discuss: decentered and no pupil centrations. Eye tracking technology was not there at that time. So the earliest approved exam laser used to closing and open diaphragms, which determine the laser ablations. All those things are not there that time. So which induced high order aberrations. The LASIK patients, we divide them into early and recent patients. Recent, we have all better parameters which gives better outcome of the cornea, whereas early patients had all those irregularity. And one of my patient who came for surgery, that patient forgot that she underwent LASIK. When we had a topography done, we saw the bizarre corneal picture, and then retrospectively we inquired her, and then she accepted, yes, I underwent LASIK for -3 correction. But her cornea was so irregular, and I could able to do only toric IOL for her, not the multifocal or trifocal. And the most important thing that factor, calculating correct IOL power in these patients will need extra attention. And the foremost thing is that ocular surface disorder which develop after LASIK. And the errors are more in case of inaccurate corneal reading and inappropriate formulas. Though we have ASARS calculations, but sometimes even that gives the range of power, that doesn't give an exact power. So we cannot able to do exact, assure the patient that patient will after surgery will get 6 and 6. So we have to only tell them guarded visual prognosis, or we have to give more chat time for the patient to counsel them to accept what it comes. So the standard cataract measurement, intermediate areas and extrapolates the central cornea, all those things my friend discussed in his details. The rule of thumb, never place multifocal IOL in eye with a previous hyperopic LASIK. If patient had myopic LASIK and has smooth topography without any irregular astigmatism, sometimes consider EDOF or the latest one. Now we have that advanced monofocal IOLs, which are very good, and patients are really happy with that. If there is irregular astigmatism or significant irregular topography, avoid diffractive technology IOLs and gravitate either monofocal, toric, or accommodating lenses. So implanting multifocal IOL can lead to significant dysphotopsias and patient dissatisfaction. As it is the LASIK patient, sometimes they complain because of their ocular surface disorders. They complain about glare and halos. Our multifocal IOL is going to add the grievance much, and the patient will complain that why you have chosen me for this. Okay. So my suggestion after laser correction is toric should be used for a higher astigmatism correction. In case of hyperopic LASIK, go for positive spherical aberration or aberration-free lenses. Monofocal IOL, and last is EDOF. The present day scenario is not like earlier one where.
Sum up, Srinivas, please.
Yes, sir. Yes, sir. Thank you.
Srinivasan, how many cases you have done with premium IOLs and how many refractive surprises you have faced?
Sir, before going to tell the premium IOLs, all these patients, remember, they are very fussy. What I do in my practice is I become more fussy. I tell them all possible things but I also explain to them, in my end mind, I want to do premium IOLs. So in my end, I will say, even for a glass when they are wearing, if there is a scratches, there is always a contrast sensitivity is reduced. There is a lot of difficulty. I tell them, when you become aged, if the glass is broken, your attender will not come for a checkup. Because attenders are so busy nowadays. Most of the time I have seen they wait for months to come for a glass checkup to change the next glass. Definitely, my first choice always is, because the patient wants that, what the patient wants, I'll go with it. But certain things like very high order aberrations and very decentered corneal LASIK corrections, I say no. Or a corneal ectasia patients post-refractive, I say no. I definitely say no. Otherwise, I counsel all my patients. And remember, one slide I missed that because of lack of time. By 2050, 50% of the world populations are myopic. And in India, it is increasing double. You go to the AOS pediatric ophthalmology session, you know how much because of the gadgets used. India is going to overtake the myopic population than compared to East Asian countries, which are dominating now. In 10 years, we are going to do. So you decide whether you want to do a premium IOL in this 50% of the population or want to do a foldable lens.
But his question was different. His question was, what percentage of your patients have a more than 0.5 diopter refractive surprise?
In post-laser visa correction, sir?
Yeah, post-operative correction.
Very less, sir. Very less. Very less. Because all these patients, pre-operatively, we do a lot of things. Two optometrists will do scan, we do the IOL master, we do pentacam. Everything we do, we take care, angle kappa, everything is taken care. then only we put them in surgery. So these patients are and not my normal optometrist do the scan. We cross check it, and my topmost optometrist only will do all the things. The preoperative workup is very important in all these patients. Without doing a preoperative workup and a proper chair time to the patient to explain, never take it.
Hello, excellent presentation. For all cases of post-classic, non-premium IOL, you select or you define the cases and select?
Pardon?
For all cases of post-classic cases, all non-premium IOLs you'll select or you define the cases and select the IOLs?
I do workup. I explain the patient about the post-surgery vision correction. Then we discuss whether the patient really wants to avoid glasses or not. But in nowadays, I prefer most of doing the advanced monofocal IOLs, which gives better results. Patient doesn't have glare or they get intermittent vision, very good intermittent vision. Only for the near vision, they have to wear glasses. So those kind of lenses are doing very good, and I'm doing those lenses for post-classic patients nowadays.
So we will ask the audience for voting.
Kavita, you
How
can be
many
on
choose
stage.
premium IOLs? Even the speaker. Okay. How many you choose the normal IOLs? Oh, yeah, good. The audience vote is different.
We are just
Anyway,
jumping.
one Srinivasan, one.
Yeah, it's now with to Kavita Lakshmi, please.
A very good morning to one and all present and to our honorable juries. I am here to advocate and strongly advocate that advanced surface ablation with all its refined forms of PRK is the present and future of refractive surgery, not just for moderate myopias, but for various other conditions as well. So in the next 4 minutes, I'm just going to break all the myths that surrounds this procedure. Seeing is believing, so let's get started. This is transepithelial photorefractive keratectomy, an advanced form of surface ablation. It is absolutely touch-free. No instrument ever touches a cornea. So there is no alcohol or suction that is applied. There is no incisions or cuts that's made, no cap or no flap that is created. It is an all-laser single-step procedure. The smart pulse laser is so many light years ahead of the age-old lasers of the 1990s, which was associated with disrepute. But this is so smooth and gentle on the cornea, and it is very quick, and what is more important is it leaves behind a biomechanically very strong cornea for your lifetime. It is a highly inclusive procedure. It can be done on thin corneas, myopias, high myopias, astigmatism, scarred corneas, as well as those with highly aberrated corneas. Enhancements are definitely possible without ever lifting or disturbing the cap. And for borderline candidates, this is a one which offers a ray of hope. Those rejected by ICL or SMILE or LASIK, this PRK is the one which offers them a ray of hope. So please be enlightened that most of the studies are done comparing SMILE only with LASIK, not with trans-PRK. So this is one such study which shows that the biomechanical stability is the strongest with trans-PRK, and it is only intermediate in SMILE. And what about the corneal aberrations? It is least with trans-PRK and it is highest with SMILE. The reason being, SMILE lacks cyclotorsion compensation mechanism and an active eye tracking system, and SMILE cannot be customized. So it requires even 0-180 marking for astigmatism correction, and the wavefront guided, topo guided ablation profiles are all possible only with PRK type of procedures. So no high cost consumables like the interfaces are required for these procedures. So well, what is the worst possible complication? It is haze, and that too it is transient, and even those which are stubborn can be treated with PTK and vision restored to normality. It is certainly not as dreaded as the ones which are described on the other side. And what about corneal ectasia? Corneal ectasia happens after SMILE, even on normal eyes and with normal tomographic maps. Whereas no evidence of corneal ectasia after PRK, even in eyes which are suspected with keratoconus. It may sound like a tall claim, but certainly no case of ectasia after PRK in eyes with after post PRK in normal eyes. So, certainly this is the procedure of choice for surgeons who put patient first and safety first before anything else. So, let us learn from the Chinese bamboo. Nothing of jiffy happens nothing of substance happens in a jiffy. And for the first 5 years, you see absolutely nothing. And in the next 3 months, it shoots to a towering height. All the groundwork, all the modeling, remodeling of the epithelium, everything happens in the first few days. And then my most happy PRK patients are the most happiest patients, but after the first 3 days. Let us replicate the cell phone revolution, the mobile miracle. India lives in centuries, even in the 21st century. Let us empower every Indian citizen. Here is an Istriwala with a 16th century cart and an 18th century wooden iron box and 21st century phone. So this is a technique and technology for the masses. What is important is to leave behind an everlasting smile and not just a fancy acronym to decode. Thank you so much.
Good morning, all. I'm Dr. Ramya Sampath. I'm here to talk to you about SMILE. As we all know, the evolution of refractive surgeries, I'm not here to talk about it. PRK being a first generation LASIK and SMILE being the third generation. And this is the comparative parameters between SMILE and PRK, although I have the rest. Where in SMILE, you can always very comfortably treat up to -10 diopter sphere. And most of the times, and most of the refractive surgeons prefer treating PRK only up to -6. And selection criteria remains the same between SMILE, PRK, or any refractive surgery. Investigations also remain the same. And yeah, so I'm here mainly to talk about the advantages of SMILE. So what is SMILE? It has a femtosecond laser with a wavelength of 1040 nanometer and with a frequency of 500 kilohertz. We have a better repetition rate laser coming called as SMILE Pro. The advantage in SMILE is it creates an intrastromal refractive lenticule at a precise pre-decided depth and position. And in SMILE, we don't have ablation-related complications. It is US FDA approved and CE marked. And the advantages of SMILE being that the better corneal nerves are preserved and you have lesser dry eye and lesser incidence of, lesser time for post-operative medications in terms of lubricants. The anatomy, when we talk about it, better biomechanical strength. The anterior most part of the cornea, the 100 to 120 is left untouched, and which is being studied by the ORA and DCT. We have studies of corneal biomechanics, which says the biomechanics of the cornea affects the functional aspects and the impacts vision. And there is no frab-related complications and it's minimally invasive. The major advantages being it's a single laser platform, independent of temperature or humidity. Keyhole surgery maintains structural integrity. It has a corneolimbal suction and less dry eye, faster recovery, no flap-related complications or haze. That's the most important thing. Lesser incidence of higher order abrasions. Other advantages being since there is no flap, there is no displacement. Unlike PRK, the patient definitely doesn't expect any pain during the post-operative period. The nerves responsible for the tearing are very less as it's intact. The predictability is very good. The procedure is very fast, precise, and convenient, and it's an office procedure. The patient goes back to his routine at the earlier stage. The treatment's effect is visible within 24 hours. Again, to reiterate, the strongest part is left untouched. Hence, the better biomechanical stability with SMILE, where the lenticule is designed in the less than 120, below the 120 microns of the cornea. Whereas in PRK, the ablation directly is over the Bowman's membrane. This is to talk about the total tensile strength of the cornea, a comparison between the SMILE, PRK, and LASIK. There are studies which says the mathematical model predicts the postoperative TTS, that's the total tensile strength, considering that higher after SMILE than both with PRK and LASIK, as SMILE has the strongest anterior lamellae remain intact. Consequently, SMILE should be able to correct high levels of myopia too. A study by Randleman et al. In 2008 says that SMILE leaves the cornea with greater biomechanical strength than LASIK or PRK. Other surgical advantages of SMILE being precise tissue disc creation is it's a solid state laser and it has no artifacts avoided during the laser procedure. It is a very silent, soft and gentle laser. The spherical aberration induction is very less in SMILE as it maintains the asphericity of the cornea, better biomechanical stability, and it is very useful in patients who are in contact sports and combative professions like Army, Air Force. And it's under one laser machine. Another important point, unaffected by the outside temperature, humidity, or draft. Again, corneal innervation. So the other comparative studies, this is one more last study which talks about SMILE and PRK. Specifically, SMILE has better results in mesopic conditions, and SMILE offers superior quality of vision and patient satisfaction in postoperative months. Thank you.
So if you had to do the procedure for your own children, which one will you choose?
Definitely the child has to postoperatively with a child having with an epithelial defect and putting the contact lens for a longer time until the epithelialization happens. In SMILE, you definitely don't require all those things. And in today's fast world where the patient is required to go back to their routine at the earliest, SMILE is my choice of procedure.
Thank you so much, doctor. And can you tell me how you manage the postoperative pain? How do you counsel your patients and make them accept it's going to take 3 days to 4 days for them to see clearly?
So actually the healing is very, very rapid in trans-PRK. It is only 2.5 to 3 days. And if it is counseled properly and if the patient is told that it's only a kind of discomfort which you're going to face and it will be there only for 2 or 3 days surgery period, they really get convinced and they are very, very happy. And during the procedure, we use a cold BCL lens. So that also helps to overcome the discomfort. But I should say that this small discomfort is worth bearing for the everlasting strength that it gives.
So do you have any patients who have haze post-procedure?
Haze so far no, but a few transient hazes have happened, but we did overcome with mild steroids and it did go away.
Thank you so much.
Thank you.
We go to the next, Dr. Arvind.
Yeah, good morning to everybody. Thanks for this opportunity. I'm going to talk about phakic IOL for keratoconus patients. So this is a modification of the intended use for these ICL lenses and so it needs to have some kind of a planning pre-operative and post-operative to achieve better results. So that's the disclaimer here. So when you look at keratoconus is the one where the left side has a normal cornea where the right side showing early changes of keratoconus. So actually I want to classify the keratoconus here because it is for the ICL use. So whether it is regular and irregular. So there is some kind of regularity on the left side. So the astigmatism can be corrected to a large extent. And this side it is completely irregular because one half of the cornea is entirely different from the other half of cornea. So these patients might not do very well. So there is another set of keratoconus depending on the location. If you look at the central keratoconus, these patients tend to do much better when you do a ICL than patients who have a decentered keratoconus. That is again very important factor which we need to look at. So progressive keratoconus. Again, this one thing which we need to keep in mind. You cannot choose a refractive procedure for a patient who is having keratoconus and that is progressive. So at some point of time we have to make sure that the patient is stable. Especially in terms of keratoconus, we have to make sure that the patient is not progressive. That means that there is no change in topographic or manifest refraction in these patients for at least 2 years. That is very, very important. You cannot say somebody is stable and then do at 18 years of age like that, unless you have 2 years of data that shows that there is no progression. So that is very important factor which we need to do that. So now that as I told you it is 2 years of stability, it can be a natural stability or it can be induced by C3R. That is the most common today because we don't want to see early keratoconus slowly becoming progressive over a period of time. and then try to do other procedures for them. So we do C3R even in a pediatric age group of even 14 years or 16 years to stabilize the cornea. So the other thing is nowadays with the technology, with especially the technology which I have, which is doing very well. So I always try to combine a TCAT, the corneal, polishing, I call it corneal polishing along with C3R. This is actually not a full refractive correction, but it tends to make the cornea much more, regular. So since we are picking up these keratoconus patients early on, by changes in astigmatism, if somebody patients are changes of more than 0.5 diopters each visit, then anyway I do a tomography, a series or a pentacam, and then see that they have keratoconus. So we identify these patients very early, and since we identify these patients very early, they have a corneal thickness of above at least 450 microns, about to around 500 microns. So these patients are more suitable for corneal polishing procedure, which is topography guided corneal ablation correction. So this has been a very great tool. So what happens in a C3R is you do C3R, the cornea remains stable, like what you have on the left and then what you have on the right. But maybe you would have seen, like in some patients following C3R, there may be a slight reduction in astigmatism and slight reduction in irregularity. Rarely sometimes we get a scarring in, post C3R. In those patients, we tend to have complete resolution of keratoconus. I have 1 or 2 patients where, they developed a small scarring, and that scarring resulted in very great improvement in unaided visual acuity. So I don't want this. I want to make it much more regular. So what is regular is when you see the pattern here, this cornea from irregular, post TCAT.
Last 5 seconds, please.
Yes. So it becomes a very stable cornea. So this is what I want. So if I can get this kind of a cornea, I can go in and do, ICL procedure. So most important, I don't want to go into the video. Most important tips is toric ICL is a very great option. Look for manifest axis and topo axis. So this has to be very, very important. You cannot have a manifest axis in one direction and then a tomographic axis in another direction. Beware, those patients might not do very well for your toric ICL. And vision post glass should be at least 618 and above. I don't want to do ICL for a patient who has a vision of 636 or below. If the corneal scar is present, ICL or similar without a hole will be better. So this is one thing which I was discussing.
But you have to finish because we have to hand over the hall.
So these are the tips for the success, and that's it. Thank you.
Dr. Preetika.
A very good morning to one and all here. Congratulations to my co-debater, Dr. Arvind sir. Some very good points there. But unfortunately, sir, better luck next time. Phakic IOL and keratoconus, seriously? Think twice. I have no interest in placing a phakic IOL in a case of keratoconus, let alone financial interest. So let me begin with reminding you all of the first oath that we all took when we all graduated from medicine, that is primum non nocere, which means first do no harm. Let alone helping the patient, saving them, everything else, first do no harm. So what is the definition of keratoconus? It's a bilateral, progressive, non-inflammatory thinning disorder of a relatively unknown cause. It induces myopia, more importantly irregular astigmatism, and may decrease the quality of vision due to monocular diplopia, halos or ghost images. So the definition itself has a lot of red flags in it which prevent us from doing a definitive surgical procedure. What are the red flags? It's a progressive condition, the cause is unknown, it induces irregular astigmatism, and already the patient is seeing halos and ghost images. So when I did a PubMed search for this debate, and when I found that all the articles actually supported Dr. Arvind's point, so I changed my view, and then I did a lot of Google search. So I started seeing from the patient's point of view, what they felt and what their experience was. So let's just go through it for a few seconds. ICL was the worst decision of my life. I'm very fine with contacts. Don't mess with your eyes. I get to see halos and double images, which is like a horror movie at night. My surgeon removed the ICL, but the damage is permanent. and I'm having the worst side effects of my life. And the last point there, think twice, think thrice before going in for such a procedure. So is Snellen chart really enough? Does it mean that if you give 2 lines improvement, the patient is going to be happy? No. In keratoconus, we are concerned about the higher order aberrations, which can be measured by aberrometry and corneal topographic elevation data using Zernick polynomials and the image on impact quality. So there are 3 parameters that tell us about the image quality. One is modulation transfer function, Steele ratio, and objective scatter index, which in turn is measured by optical quality analysis system. So what is modulation transfer function? It talks about the contrast of retinal images with various resolution. So if the curve, it's a curve, so if the curve is low, it means that the quality is low. If the curve is high, it means the image quality is better. So if a value of more than 1, it means the image quality is better. And Steele ratio, just like MTF talks about contrast, Steele ratio talks about luminance. And if the perfect ratio is 1. And what is objective scatter index? It talks about intraocular scattering of light. If the scattering is less, the image quality is less. So if it's less than 0.5, the scattering is less and the quality is good. And if the scattering is more than 1.5, it means there's a lot of scattering and the image quality is not good. So you might treat the ametropia, but you are not treating the aberrations. The aberration associated with the refractive error in keratoconus associated with phakic IOL have an effect on the ultimate vision quality. So this is what I said, the corneal aberrations in keratoconus adversely affect the visual quality. So we have to be very careful with patient selection. You cannot select a recently diagnosed keratoconus patient, young patients, or patients with progressive keratoconus. As sir already mentioned, stable keratoconus at least for a period of 2 years. So would you do this procedure for your relative? If the answer is no, you also know what the answer to this debate is also. And finally, I would like to conclude, just because the learning curve is less, just because everybody can do the procedure, and just because you give a patient of 2 Snellen's chart, visual acuity is going to get better, doesn't mean the patient is going to be happy. So don't burn your fingers unnecessarily. Thank you.
Time. You are finished within the time.
Thank you, sir.
Audience, your opinion?
As he said, it is very right. It has to be very selective. As I told you, if we have other technology to stabilize and make the cornea more regular, then ICL will be a good choice. So it's not for every keratoconus patient.
Next topic.
Good morning to one and all present here. So any phaco surgeon would not like to have a posterior capsular rent during his surgery. Posterior capsular rent can either occur during phacoemulsification, during cortex wash, or any IOL implantation. So what do we do when we have a posterior capsular rent? First thing, do not panic. Don't stop the irrigation. Just inject some viscoelastic and pull the probe out. Stay in irrigation and pull the probe out. And then you can proceed with either pars plana vitrectomy or anterior vitrectomy through a limbal approach. In cases which straightforwardly require pars plana vitrectomy, like nucleus fragment drop, there is no doubt you have to go ahead with the pars plana vitrectomy. But do all cases need a pars plana vitrectomy in cases of PCR and phacoemulsification? The answer is no. You can go with, you can manage the case safely with limbal approach. And one more thing, you can also intervene the patient at the same time immediately, or you can have a delayed approach. You can wait for the eye to settle down, the inflammation and the intraocular pressure to settle down, and the cornea to heal, and go ahead with the delayed intervention also. So anterior vitrectomy, as we all know, is clearing the vitreous in the anterior chamber and the anterior vitreous face, so that it doesn't interfere with the IOL implantation or doesn't incastrate in the wound, causing vitreous traction. So the steps are make a sclerocorneal tunnel if needed, but open the tunnel only before inserting the intraocular lens. Make side ports, and you can stain the vitreous with triamcinolone acetate and start cutting the vitreous, and take care not to pull the vitreous and not to harm the cornea. So once the vitreous is cut, and one more thing, you have to take care not to extend the posterior capsular end. We need the capsular support to either place a 3-piece lens. And after the vitreous cutting is over, we can go ahead with the cortex wash, but careful cortex wash. We have to make sure when the vitreous is clear in the anterior chamber. And place the appropriate intraocular lens, whichever you are comfortable with. So why do I support anterior vitrectomy through a limbal approach? The first is the ease of accessibility of both the instrumentation and the specialist. You don't need a hi-fi vitrectomy machine like Constellation for the procedure. Most of the phaco machines come with the vitrector, which is very easy to do an anterior vitrectomy. And the specialist, you don't need to take appointment from the retinal surgeon. You don't need a readily available retinal surgeon for the procedure. And it has a very short learning curve. Any anterior segment surgeon can learn the procedure easily and can perform it. And in the last 3 months, we had done 27 patients who had PCR after phacoemulsification. These are mostly camp patients. Since we are a training institute, we get more cases. And most of the patients, around 85% of the cases, had good visual acuity after 1 week of the procedure. And finally, coming to the complications related to the pass plan approach, we do not have any complication related to trocar in anterior vitrectomy limbal approach, like port site leak or following hypertony, and port site granuloma, iatrogenic retinal breaks following retinal detachment or vitreous hemorrhage, and choroidal hemorrhage. So to conclude, I would say that anterior vitrectomy through a limbal approach is a very safe and effective method to manage PCR during phacoemulsification. But it's always better to know both the techniques and apply whatever technique you are familiar with for the benefit of the patient.
We'll just put in a question now itself.
Yes, sir.
What are the instrument you're using for vitrectomy? What is the left-hand irrigation thing? Is it the IV line? Simcoe?
Yes, sir. It's Otley phaco machine we use, sir. The irrigation is connected with the machine itself. Okay. We don't use a separate irrigation solution for it.
Okay.
What kind of implants do you use in these patients after you do the anterior vitrectomy?
If we have an adequate sulcus support, sir, we place a 3-piece intraocular lens in the sulcus. If we do not have an adequate sulcus support, I place an iris cloud lens.
And what percentage of your patients have vitreous tracking till the wound in the post-op period? Because the main problem is that in some patients the vitreous will track till the wound.
Yes, sir. As far as I know, I haven't seen any of the vitreous traction in my cases, sir.
Superb.
Yes, sir.
You have said 24 cases of posterior, PCR was there.
Yes, sir.
High thing.
Yes, sir. Since we are a training institute, we get a lot of posterior capsular ends induced by the trainees, sir. Mainly these are in camp patients. Yes, sir. Thank you. And I would like to thank everyone for giving me this opportunity. Thank you.
So, respected teachers, senior ophthalmologists, my dear friends. So, I'm going to defend myself saying that the new thing is the pass planner approach. So, anyway, I had a tough opponent here, so I'm sure that I cannot beat her in 2 things. Her boldness, because that comes with young age and her charming looks. But when it comes to PCR management, that is my gold standard. I'm sure that I'm going to win. So, basically, about science and anatomy, all of you know we have the anterior chamber, lens, cataract. So, you deal it the anterior approach and do phacoemulsification. At the same way, you have the posterior segment, you have the vitreous body there. So the way to manage it is the pass plano approach. So if all of you have understood this, then I think you should accept the defeat graciously that pass plana is the way how you manage the vitreous. So this is a case where you have a decentered lens with vitreous prolapse into the anterior chamber with cortex. Using the trocar is very simple because we are doing complicated cataract surgeries, which is such a skillful surgery. So just putting a trocar needle in the eye is just going to take a matter of practice, and we also have wet labs here in the same conference. So once you have there, the main goal is you are cutting the vitreous from where the pars plana is. So you have lesser amount of vitreous to cut, you get good adequate vitrectomy. As you can see here, once you do the anterior vitrectomy, the block that is actually come outside, So that also gets sucked inside because you're cutting it at the base and not pulling it from anterior approach. So once you do a good vitrectomy, then you remove all the cortical matter that is there, and then this is how the case ends well. So we all have to accept that the only thing that is constant is change. So the times are changing. So phaco has changed, LASIK has changed, so has vitrectomy. So yes, we were doing the anterior approach before. So this is a description from my friend Dr. Samresh, who was very beautifully explained. When you're pulling it from front, the vitreous, you see the block keeps coming and there is chances of the extension also happening of the rupture. And you don't know when to stop because you keep on cutting a lot of vitreous. But the same thing when you use the pars plana approach, you see that the vitreous that is prolapsed outside, when you're pulling it back, basically there is no extension of the margins of the rupture. So this is again, even though it looks like a very large PCR for any vitreous prolapse case, staining is very important because once you stain and wash it away, you can see only the vitreous strands that are stained. So this shows you how much of vitreous to cut. So always stain for all cases of PCR. And then again here the posterior approach, you see, you know exactly what to cut rather than just going blindly anteriorly and keep cutting more. And sometimes when you use the AC maintainer, the more of the saline that goes inside can cause more of the vitreous to prolapse and hydration of the vitreous. So here again, as sir said before, make sure there is no vitreous in the sections. So once you make sure you swipe it and see, and the pupils are round because sometimes this vitreous strands get stuck into the section, and then we all know that the chance of endophthalmitis increases. And this particular case, we are keeping this rigid lens in the sulcus. So there are articles that are suggesting actually when you do a pars plana approach, the time is also shorter. So this is a Miyake view showing you when you go through the anterior approach, see how much of movement is there at the bag lens complex until how much can you reach when you come through the anterior approach. The same thing when you do a pars plana approach, you see you can actually go farther away and do more of the vitreous, and actually the IOL bag complex doesn't move. So these are some of the advantages when you actually do a pars plana approach. So the only problem is using the trocars, but I think after some good practice, that should not be very difficult. Now I know most anterior segment surgeons are also using intravitreal, so it's almost the same as that. So the main goal, why a good vitrectomy, because post-operative, we don't want to see any vitreomacular tractions like this. We all know the chances of endophthalmitis is also fourfolds when there's some vitreous, and decentration of the IOL. So there is advantages of both. Yes, we were doing the vitrectomy anterior approach before, but then now slowly it is good to know both techniques. So as Dr. Amrita said, the anterior approach was like Tendulkar, long tested time and was proven. But then when only Dhoni came inside, they could win the World Cup. So the best is good to know both the techniques and for which case you should use. So one technique doesn't suit all. So it's good to know both the techniques. The choice should be based on the stage of PCR, amount of vitreous that is available, and also have the right instruments. So once again, thanks TNOA for this wonderful opportunity.
Nivian, thanks Nivian. A beautiful presentation and you finished in time. So in which patients will you choose the anterior approach and which patients will you choose the posterior approach?
So suppose first I agree that I won it, then I defend. So suppose you have a small rent.
We also want to learn from you, Nivian, please.
Suppose you have a small rent at the end of the surgery, and those cases, I think the anterior approach is better actually, because you don't want to go through the pars plana. And as she showed, we have 2 side ports. So don't use the main ports. That is the only advice, because a larger wound sometimes can prolapse more of the vitreous when there is a sudden decompression of the anterior chamber. So just maintain your chamber, and then anterior approach is better in those cases. But sometimes when you have the nuclear managed, the last piece of the nucleus, and in those situations, I feel the pars plana approach is more stable, because once you have the trocar inside, so the fluidics are better, that you don't have to keep putting in more and more viscoelastic inside. So that reduces the post-operative inflammation also. So it depends on every case. And
So most of us don't have VR training. So how many posterior approaches should we do before we get sufficient skill so that we don't have complications?
Sir, you're a skilled surgeon. Maybe 5, so because I think today we had the first wet lab actually here. It was very nice to see a huge crowd. So I think it is just a matter of 1 or 2 cases, I feel. So because I think phaco is a complicated surgery, not complicated phacos. When we're able to do phaco, I think putting in a trocar just to cut a vitreous, it is only the mind block. So I think we should all get over it. And as you know that all anterior segment surgeons machines have a vitrectomy there. It is only that we don't use it, and cutters are available. And
Nivian, one last question. So we always say that we have a smaller PCR if you go by the posterior approach, but most of us are not putting a in the bag implant in these patients. We just need the anterior capsular exists to be intact. So what's the need to preserve the posterior capsule and have a smaller tear there?
So but you all know, no. So the first choice should always to have the lens in the bag. So this is actually going to prevent the extension of the rupture, and even in PPC cases, isn't it? So we have had large ruptures and managed posteriorly, and we're able to still put the lens in the bag. Will be the first choice, not in the sulcus. Actually, we have even done multifocal IOLs in the bag after a past planar approach.
And again, you are equally charmed, and we don't judge by seeing the faces.
I just wanted to make it clear.
Any questions from the audience to any speakers? Yeah, thank you. We'll close. Sir.
கை வைக்கக்கூடாது.
அதே ஆர்டர்
Good morning, ma'am.
Thank you.